In terms of secondary prevention, what we know is that if you've had a heart attack or you've had stents put in or you've had a bypass operation, we then give you a whole bundle of tablets. Aspirin, cholesterol-lowering tablets called statins, beta blockers to slow your heart rate down because we know slower heart rates are associated with better outcomes, and drugs called ramipril which lower your blood pressure and improve the remodelling of the heart. And in fact, if you look at the clinical studies, there are 15 or 20 tablets that potentially have benefit, but you get a reduced benefit once you go beyond 5 tablets. You get not as much gain as you add 6, 7 or 8. So we use a core of 4 or 5 tablets. Now, what it does appear is that there are 2 groups after having a heart attack. There are the group that actually do very well, and these tablets are enough. And there are the group that don't do quite so well. And that group, generally what is done at the moment is that in the UK we just watch people, and if they have another event at 3 years then we intensify treatment. So after you've had a heart attack and you've been treated, we quote a 15 to 20% chance of having another cardiac event in 3 years and as much as a 30 to 40% at 5 years. But actually what's happening is that a small cohort are having the events and the rest are actually quite well. And to identify that group, you can do vascular screening, which involves a whole plethora of blood tests that are done in the United States that you'll be able to read about on the internet, that include highly sensitive CRP, ApoB and ApoA ratios of cholesterol, lipoprotein small a, and homocysteine, for example. And these things allow us to optimize or intensify specific statin treatment to try and make things better. It's a bit like fine-tuning. And although we don't have all the outcome data to say that this definitely makes a difference, what we do know is that if you are going to get benefit from a statin, and if we do this and we can fine-tune it for you to be potentially on a better statin, then actually you've got nothing to lose and you've potentially got something to gain. So again, I have an interest in this, particularly in young people. So I have a lot of young patients of 30, 40 and 50 who've had heart disease early. And of course they're going to run into trouble because their life expectancy is still 80, and I've got to worry about them for the next 30 years. So we've got to get it right, and I feel very strongly that we have to get it right, and therefore we should do this early in the process.